Good afternoon, everyone. Welcome to this webinar on clinical reasoning remediation in mentorship. Thank you for taking the time to join us this afternoon. Just a couple of reminders to close any applications running on your computer. This will help you maintain a stable audio and video connection. If for some reason you're having some technical difficulties, your connection freezes, we recommend that you exit GoToWebinar and rejoin. There should be a box on your screen where you can enter questions if you have any while you're listening today. Our colleague Jessica will be monitoring those, and we will take questions at the midpoint and at the end. And you will have access to the recording and slides for this webinar. They will be posted on the Mentorship Program webpage. So I'm Samita Joglekar. I'm the Audiology Advisor and Manager of Mentorship at the college, and it's always a pleasure to be joined by my colleague, Sarah.
Yes, thanks, Samita. Hello, everybody. I'm Sarah Chapman-Jay. I'm Advisor for Speech Language Pathology, Practice Advice and Quality Assurance. And as Samita mentioned, we do have Jessica Laforette, who's also assisting us with questions.
Yes, thank you. So our agenda for today. Our goal today is to give you practical guidance on how to identify and remediate gaps in clinical reasoning in mentorship. So if you're listening as a mentor, we are hoping to give you some nice tips and practical guidance on how to do this. But we also think the information today can be useful in your everyday practice, working with colleagues, and also working with students. But our focus today is to help mentors in the mentorship process. We are going to listen to audio examples of remediation in action, and we hope to get to your questions, of course, halfway through and at the end. The webinar today builds on the information in Module 2. So last year we did a webinar on the clinical reasoning tool in mentorship. So if you haven't watched this webinar, it will be helpful background information for you. So just a quick review of some important information. So mentors and mentees have used the clinical reasoning tool, or CRT, to assess clinical reasoning since October of last year when we introduced it. And as a mentor, you're using the clinical reasoning tool discussions to assess the indicator for clinical reasoning, which is 3.7. And in the mentorship self-assessment tool, this indicator for clinical reasoning is a red flag indicator. And what that means is that mentees are expected to meet this indicator by their midterm. So if a mentee receives the rating of needs work to meet the standard at the midterm, after completing 2 clinical reasoning tools, then the following happens. So the clinical reasoning indicator populates in the midterm report as still needing work. Mentors comment in the report on how clinical reasoning skills will be addressed during the remainder of the mentorship, and the mentee prioritizes clinical reasoning as a learning goal. Again, if the mentee receives that rating of needs work to meet the standard for clinical reasoning, then mentors are conducting the clinical reasoning tool for 2 more case discussions at the final evaluation, and then commenting on the mentee's progress with clinical reasoning in the final report. So we know that clinical reasoning skills develop over the career span, but they are an important entry to practice competency. So a mentee must meet the standard for clinical reasoning by the end of the mentorship period. But in mentorship, there are some considerations that you would be making. So as a mentor, you are going to be considering the mentee's career stage. So the fact that they're at the beginning of their career and just beginning their professional practice. So their experience level is something you need to consider. It may be limited, especially if a mentee has never worked in a particular area of practice before. They may be needing to develop their skills, and that may be reflected in their clinical reasoning. You're also looking at the practice environment that the mentee is working in. And you're also looking at the mentee's demonstrated motivation to accept feedback and continually improve. their clinical reasoning. So over the course of the 6-month mentorship, has the mentee shown that they understand the importance of this practice standard for clinical reasoning, and that it is an area that they can continually reflect on and continue to improve in. Mentorships are extended if clinical reasoning skills still need work at the end. So why do we require the clinical reasoning tool in mentorship? Well, firstly, it's a really nice tool that CastlePo has. It provides a really nice framework for these discussions. And the reason we decided to require it is for something called risk-based regulation. So our goal is to mitigate the risk to the public of having newly practicing SLPs and audiologists in Ontario who have not demonstrated adequate clinical reasoning. We want to identify the mentees with gaps in clinical reasoning early, and we think that mentorship is a great opportunity to do this and a great opportunity to remediate the clinical reasoning skills through mentorship. So looking at mentorships that have happened since last October, over the last year since we introduced the clinical reasoning indicator and the tool, we've had 220 mentees in this last year. And it's really nice to report that the vast majority have done extremely well in this area. So the feedback that we've received from mentors and mentees on using the clinical reasoning tool has been really excellent. And we've seen some very positive comments in the reports that we review from mentors on how mentees are demonstrating clinical reasoning. So that's been really wonderful to see. What we find is that about 2% of mentees have had clinical reasoning identified as an area needing further support. And this finding in mentorship is good. It's good for public protection. Like I mentioned, it means we're identifying mentees who need that support early, and we can remediate early. And this is where you come in as a mentor, because you are spending time with your mentee for 6 months, and during that time, you can be very influential and really help a mentee if they're showing gaps in clinical reasoning. So at this point, I'll turn it over to Sarah to talk about the clinical reasoning remediation program.
Thanks, Amita. Yes, so we did actually develop a clinical reasoning remediation program for quality assurance. And so that's the reason today we thought it'd be very helpful to also share this with you in mentorship. So with the clinical reasoning remediation, our aim is to have a program that incorporates adult learning principles. So we're hoping you can make the program as self-directed as possible. We want it to be as relevant and practical as possible, incorporate learning by doing and respecting the clinician and building on successes they already have. So because the mentors and mentees who've already been involved since October 2020, many of you are already using the clinical reasoning tool as a framework to guide case discussions and to gauge the clinical reasoning skills of your mentee. But what's important to notice is that you can also use this tool with remediation. So the tool examines the processes that reveal clinical reasoning. As a mentor, you can elicit further clinical reasoning by using the prompting questions that are in the tool. And if needed, you can expand on those prompting questions. So what we're going to do is just a refresher on what the processes are. There are 7 of them. And what you're doing is, in terms of remediation, this is where the mentor may have some trouble in some of these processes. So let's just quickly review what they are. It's collecting sufficient information, checking that they apply background clinical information in their decision making, that they're linking information from one phase of intervention to the next, that they're really being patient-centered, taking that patient's context into consideration, that they consider options. They don't just choose one every single time that they're providing intervention. There are options and a sort of bag of tricks that they can look at, showing some flexibility in how they approach the patient and the options, and above all, reasonable rationale, that they can explain why they did what they did. And also in the clinical reasoning tool, there are discussion areas. So it's broken up into these 5 areas: the patient overview, which is background, developmental history, medical history, screening and assessment, management, which can include many things: treatment, consultation, monitoring, discharge planning, and or follow-up, and finally, practice reflection, which again is a key concept we'll be exploring further. So again, you might notice there are some gaps in one or more of these areas. Maybe they can screen or assess really well, but maybe they're falling down in the treatment, setting up goals, intervention area. So let's zoom in a bit on what the clinical reasoning tool looks like. We are showing you the section on screening and assessment. And as you can see, there are some prompting questions. So in this screening assessment section, there's question 3 and 4, but there are also included some bullet points. So more than the question, how did the background information direct your assessment? If you're not eliciting a lot of discussion with the mentee, this would be a time that you could ask those additional questions. Tell me why you chose the test you did. What other possible tests are there? Why did you mainly choose formal? Are there some informal approaches you could have used? Tell me a bit about the restrictions collecting information. What interprofessional collaboration has taken place so far? So these are prompting questions that you can use when you're using the clinical reasoning tool, or subsequently when you identify that there are clinical reasoning issues to discuss. And on the right-hand side, there is a comments box. You can see the legend CA, which is collect, apply, link, patient context, etc. But again, you can write your own comments in here as a way to provide some real feedback to the mentee, or the mentee could actually use this comment box as a way of thinking out loud. If they're really having difficulty in thinking about what their reasoning is, then that can be helpful. We're also going to discuss critical thinking, reflection, and problem solving, and how these concepts are going to be useful for remediating clinical reasoning skills.
Yes. All right.
So, yes, at this point, we have selected 4 different audio examples. We're going to listen to the first one, and Samita's going to get the audio clip prepared for us. And you will recognize the voices. These examples are fictitious, and the first one is going to be an SLP example. And we're going to be polling a question after this, and it's going to be asking you from the audio example, which clinical reasoning processes were shown? Collect, apply, link, patient context, flexible, options, reasonable rationale. So Samita, I think we're ready for the first audio example.
Perfect. Just take a moment to get it started.
Lovely.
Tell me what is interesting about this case.
Well, the boy, his parents were concerned about his stuttering, so I talked to the mum on the phone. She didn't have concerns about his sounds or his words, just his stuttering. So I took her at her word, and I just assessed stuttering.
Okay. So how did you choose your assessment?
I usually go with a speech sample.
All right. And what would lead you to choose that method over maybe other methods that are available?
It's an undiluted snapshot of the child's speech.
Okay, so can you tell me, how did the assessment process help you develop your recommendations or your management plan with this child?
Well, he's 4 years, 7 months. He's hardly stuttering at all. I took Mum's word for it. I said to Mum, most of the time it just goes away if you just wait. He'll be out of senior kindergarten this year, and then next year he won't be able to receive services. But let's just wait and see.
Mm.
And then Mum called me 2 months later and says it just isn't any better. So I took her at her word, and I started with the Lidcombe approach. I had some new speech samples, which now showed a mild to moderate level of stuttering.
Mm-hmm. Okay, so how did those assessment plans change your therapy plans?
Oh, didn't change it at all.
Didn't change it at all. Okay. Did you involve others in the intervention? Any other healthcare providers or family members? And how did you come to that decision?
No. I talked to the mum, and who else? No, it was just Mum.
Just the mom. Okay.
Mm.
So, knowing what you know now about this child or about this case, is there anything you might have done differently?
Mum knows best. I took the mum's word for it, her word for it, and yeah, that's what I did.
Okay, thank you.
Excellent. Okay, so what Sumita is going to do now is post the polling question for you all. You should be able to select one of the following. Did you hear any of these processes? And just select one of them, all of them, some of them, none of them. I'm not sure. We'll give you a moment to do this.
Yeah, we've got some responses coming through.
Excellent.
Already. Just wait another 20 seconds or so, and then I'll close the poll and share the results.
Thanks, Sumita.
Okay. All right, let's close that poll, and I'll just share those results so you can have a look at what the attendees are saying here.
This
So we
is
have
excellent.
we have a small number, 6% are saying all of the processes were shown. The majority are saying some, and we have 23% none, 4% I'm not sure. So let's
Excellent.
see, quite a range.
Yes,
There.
yes.
All right.
So I think it's important to note right now, I mean, we've just heard this one clip and we're asking you to, make a decision very rapidly. But if we're to review this, we would say we're seeing some, but very slight. Like we're not feeling like it's fully sufficient background developmental history being provided. The comment was very much it's going by Mum's word. Some minimal background clinical information in the decision-making process. They did come to the conclusion there was a mild, moderate stutter and decided on the Lidcombe approach. But really the rest, again, very minimal, or they weren't considering different options or showing a lot of flexibility. And the response was, didn't change my plans at all, or why would I do that? So I think this is a good time that we are now going to focus on how we would remediate some of these processes. Now, again, we want you to understand, of course, you're not going to do this all in 1 hour like we're trying to attempt right now. You are mentors, mentees are working together for 6 months. So, but we're going to take a couple of examples here, considering options and showing flexibility, and then following up with reasonable rationale.
Right.
So, yes, over to you, Sumita.
Yes, thanks. Yeah, so absolutely, there are other processes that definitely we didn't get to hear in that example, and some time would need to be spent with this mentee to really reflect on all of the 7 processes. But let's zoom into 2 or 3, considering options, flexibility, and reasonable rationale. So starting with considering options, this was a clinical reasoning process that was lacking in the example we heard. And as a mentor, if you're noticing that this is a gap for a mentee, again, there could be different reasons for that. It could be because they have not worked with stuttering before. This isn't an area that they've been exposed to, in their clinical placements as students. So what you're going to do as a mentor is really encourage a lot of thinking, a lot of reflective thinking and brainstorming. So you can encourage a mentee to generate plausible clinical hypotheses from the assessment or the background information. What do you think you might see? What do you think you might do? You can encourage a mentee to provide well-reasoned options for the patient plan of care, and you might have to give the mentee more information using your own knowledge and experience. You might find that you're giving them a lot more than you would need to give a more experienced clinician. So asking the mentee to brainstorm options around management strategies, what are the alternative options, pardon me, and to continually evaluate and modify the patient plan of care if necessary. Looking at flexibility, this again was a process that we didn't see that in the SLP example we listened to. Sarah elaborated on some of the ways, just going with one approach, only taking the mom's word for it. So you want to encourage a mentee, if this is where you're seeing gaps, is to encourage them to think of ways to adapt their approach regarding the patient. If they discover that the patient has certain needs, what are the choices available? What are the intervention options available? Identify discrepancies and unusual patterns in the therapy process and attempt to reconcile unexpected results. So encourage some thinking outside of the box. And part of being flexible is also to incorporate others' opinions and ideas. So encouraging the mentee to incorporate other healthcare providers' goals in the patient plan of care. So what about the teachers involved with the child? What about other health professionals? What information do they have and how can they bring that into what they would do in speech language pathology? So that's showing flexibility. More on flexibility. So encouraging a mentee, this is an important one, to be open to changing an opinion when presented with reliable and valid counter evidence. So sometimes it's easy to get stuck in one particular way of thinking, but part of being flexible is to be able to take new information and to think, okay, how can I open myself up to a different approach? So to continuously evaluate the assessment and management plan and modify if necessary. And collaborating with the patient is also very important. What is the patient telling you? What information is the patient giving? So involving the patient as well as a part of flexibility. So I think at this point, what we'd like to do is listen to another audio example. So we're going to listen to the same mentor and mentee having a discussion, and this time we'll listen to the remediation actually taking place. So it just will take me a moment to get that audio clip started. Sarah, do I still have you with me?
I am with you, Sumida, and yes, we are looking forward to this second audio example.
Great. Let's delve into the question of how assessment plans change your therapy plans and consider options and reasonable rationale. Okay, so when a parent has concerns, you want to acknowledge their concerns and take them seriously. So ask yourself, what are the alternatives to taking mom's word for it? What other approaches to assessment could you explore?
Well, I could look at some additional informal or formal assessments, but I don't know where to start.
Okay, so let's talk a little bit more about that. So given the variable nature of stuttering, how about speech samples from a variety of speaking situations to help figure out the nature and type of stuttering behaviors? So you could think about your choice of tests and approaches that you would use. You've heard from mom. Can you think of anyone else who interacts with this child?
Okay. Well, the mum did share with me. So this child, he has 3 older siblings, and at the moment he goes to senior kindergarten, but I don't know how they interact with him.
Right, but so that could be helpful though. That's helpful information. So let's think about how you can obtain more information about how the boy interacts with them. Could you give me some examples? What are your thoughts around that?
Well, I could ask the mum if she was happy to record or video some interactions with the siblings, obviously with consent, and review the data.
That's good. Good ideas. Any other ideas you have?
I could observe them in action during a session, maybe invite one of the siblings in and then actually watch him interacting with each of them. That would be maybe good.
Yeah, that sounds like a really great idea. Okay, so when you have these additional speech samples, if you do watch their interaction during a session, what will this tell you? How could you analyze the samples? And if it helps, you can refer to any notes you have on this to remind you.
Okay, well, so I know, so I could do this with all of the samples. I could analyze the frequency of primary and secondary stuttering behaviors, and obviously take a look at which are normal non-fluencies, which are stuttering behaviors. And I can calculate the percentage of syllables or words stuttered and measure the speech and articulatory rate. And also, actually, if I record it or observe, I could also check for signs of tension, how and different ways he reacts and responds to others when he's speaking and when he's interacting with them.
Okay, really good. Yeah, I think those are great ideas. And I think that will help you to have a much clearer assessment of his stuttering behaviors, and it'll help you figure out what steps to take next with intervention. So you would be looking at things like, when is he most comfortable? When does he speak easily? Who does he talk with? And which situations are challenging for him? So can you tell me, how do you think you could involve others in the intervention, considering he is in senior kindergarten?
Well, I could maybe approach his teacher and find out their observations and explore if there's a rating scale or some kind of observation checklist that they could fill in. But where could I find one of these?
Good question. So I can share my ideas with you. And I could also suggest that you review any information you learned from your clinical placements or in school. I mean, we all have questions, and it's always good to chat with peers or leaders in the field when we have these types of questions about current best practices and resources. It's a great way to keep informed and also to consider options.
Okay, I like that. Thank you.
Okay.
Excellent. So, all right, so let's just look a little bit about what did the mentor do differently this time. So it wasn't just asking the first questions. They did probe more. They encouraged the mentee to expand on their thinking. They were asking questions like, you know, how about, or even giving comments. How about speech samples from different situations? A variety of speaking situations. Is there anyone else who interacts with this child? You know, who else could you involve in intervention, considering he's in senior kindergarten? And obviously realize the mentee is less experienced. So in this case, needing to give some more suggestions and ideas to help with the problem solving and encourage that critical thinking, thinking ahead and thinking back. And what did we see the mentee do differently this time? So they were able to give some more well-reasoned ideas. They were talking about how they would analyze the assessment results, the speech samples, thinking ahead, thinking out loud, acknowledging, and this is good about the insight, you know, I'm not sure what scales are out there, or observation or rating scales. So this is a good way to have that conversation together. And there was some more evidence of problem solving. So this was great to see. So yeah, so on the next slide, what we will look at is we will acknowledge, yes, the reasonable rationale was insufficient maybe this time round. So let's imagine this was a midterm clinical reasoning tool situation, and the mentee and the mentor are realizing, okay, we need to build on these skills. We need the mentee to elicit greater reasonable rationale behind their clinical decision making. So what can you do at this stage? Well, you can encourage the mentee to do the following. And this is a big one. So you need to help them explain why they did what they did. So help them justify why they chose a certain assessment or certain intervention when they're working with the patient. Encourage them to refer to best practice evidence, check into information they learned in school, previous placements, and help them do more reflection on what worked well, why it did, what didn't work and why. And really developing some well-reasoned options, using what they've learned, using evidence, and practice knowledge, which we acknowledge, you know, we build up over time. So they're going to benefit from your experience when they're really feeling like they aren't able to demonstrate clinical reasoning. In this case, it seems to be very specific to this area of practice. So I think, Samita, this is our first opportunity to check in with Jessica and see if there are any questions out there. Jessica.
Hello. Okay, I have two questions.
Yes.
One, someone actually have a third. It's a very quick one. Is someone would like to see if you would be able to share the clinical reasoning tool on the screen. Wondering if you have a chance to do that, or maybe direct them to where they can find it.
That is easy. Yes.
We can do that. Yes, we could do that. I could also answer it if that person wants to contact any one of us directly. We can show them, but you will find it on the mentorship webpage. So yeah, we can figure out a way to do that.
Wonderful. Okay, the next question, sorry, I just need to pop out my screen. It was popped out, now it's not. How did that happen? Hold on 1 second. Okay, so the first question I have is, should we do remediation at the time we are administering the tool or after?
So I would say at the time that you're administering the tool is a great time to start doing remediation because you're right there in the moment discussing it with the mentee. So if you can give some suggestions at that time. We're going to talk later on about critical thinking and thinking back and thinking ahead. So, and problem solving. So it might be that you say to the mentee, tomorrow, let's talk about a hypothetical situation, or let's simulate something and we can do some problem solving. But I would say as you're doing the clinical reasoning tool, that could very well be a very good opportunity to remediate right at that moment. What do you think, Sarah?
Yes, Samita, I think it depends how familiar you are with the tool as well. And I will admit, I mean, I've used it in quality assurance, and what was really helpful to me was actually I just did a practice with a peer. I just, ran through the tool because, first of all, you're familiarizing yourself with the questions, and then in addition, the prompting questions. So that could be another approach, is actually do a practice just with your peer, or even do a couple of practice runs with your mentee and then say, okay, now let's really use it for another patient. So, I mean, there's no limit to how many times you can use the tool. I think that's the beauty of it. So yeah, that's what I would add to that. Yeah,
for sure.
Great answers. The second question I have is, would you recommend recording the clinical reasoning tool questioning for later reflection by the mentee?
Sarah, what are your thoughts around that one?
Yes, we like that. Yeah, absolutely, because recording, just like we use it in therapy, we might record interaction and then use it as an opportunity for feedback, insight into, how we respond, how we speak, etc. So yeah, there's, of course, with each other's consent, but recording it is a great way to reflect, even as a sort of measure. If you have concerns about remediation, you could do the midterm one recording and then maybe at the end and see the progress, hopefully, over time as well.
I
What
was
do you
just
think,
thinking,
Samita?
just thinking the same thing, that it could be a great way to measure progress. Of course, in mentorship, it is a 6-month period. So it would be a really nice learning tool for both the mentor and the mentee to listen back. What was the clinical reasoning earlier in the mentorship? And then as the skills developed and the mentee built their experience, how did it change? Because as I mentioned in the beginning, or we said in the beginning, this is a competency that develops over your career span. So yes, thank you for those questions. Do we have any more, Jessica?
No, that's all the questions we have. So if anyone has any
Wonderful.
more, feel free to send me questions in the question box.
Yeah,
Oh,
fantastic.
I just got a couple more, but if you want to wait, I can wait until after.
Yeah, I think if we continue, we want to cover all our
Perfect.
material, and hopefully we still have plenty of time at the end as well. Excellent.
Wonderful.
Okay.
Thank you.
Thank you. So actually, we're just going to get right into our next audio example. So this is a clinical reasoning example from audiology.
Okay, so can you briefly give me some background and tell me what was unique about this patient?
All right, so this is a patient who has been coming to us for a few years. I believe he's a retired teacher, maybe about 72 or 74 years old, I think. Sometimes he comes in for cerumen removal, sometimes it's for other things. But on this particular occasion, I think he came in with, he came in with the complaint that he woke up one morning and he had lost his hearing in his left ear, completely and suddenly. I mean, I don't have the audiogram from that time here with me or anything, but he said that he took some prednisone and then his hearing basically returned. But his right ear, it has a very mild high frequency hearing loss. And well, he's about 72, I think 72 or 74 years old. So, I told him that's to be expected. But, my feeling is that his hearing has always been symmetrical between the right and left ear. I mean, I don't have the hearing tests with me, but that would be my guess, based on memory.
Okay, so could you lead me through your assessment process? How did you go about assessing his hearing?
My assessment process. Let me just look at the file. Well, so on this day, he was mild to profound. I think that's profound. Is that 80, 100 dB? I think, yeah, I think that's mild to profound loss in the right ear. So I basically wrote acute hearing loss in acute hearing loss in August, and then I wrote resolved because he reported it was resolved. But in fact, it's probably resolved compared to what it was because he said he couldn't hear at all. So, he took prednisone and that gave him some relief. So.
Excellent.
Okay, we're going to stop that one there. And my apologies, I meant to show you this polling before we listen to the clip, but we want to launch the same polling question. So thinking of that audio example you just listened to, which clinical reasoning processes were shown? So I'll just launch the poll. And we'll just give a few moments for our attendees to respond.
To respond, yeah.
I can see the responses coming through. Just wait another 10 seconds or so. Okay. So here's what our colleagues are saying. So mostly some or none.
Yeah.
Okay. So this is a clinical reasoning example we put together to show some gaps. Definitely some gaps in clinical reasoning happening there. I don't think we had the opportunity to really hear any of the 7 processes that we would be looking for, that you would be looking for as a mentor or as a mentee that you would be reflecting on. So we heard the audiologist there say, going on memory, I don't have the audiogram information with me. So as a result, we didn't really hear much of applying information or linking information or taking into account the patient context. When the mentor asks, can you tell me what your assessment approach was? The mentee didn't really describe their assessment. They sort of were talking around that, but we didn't really hear the mentee describe how they assessed that patient. So in terms of considering options, being flexible and providing a reasonable rationale, that wasn't shown in the clip that we listened to. So if this was happening in mentorship, it would definitely mean that some time needs to be spent on clinical reasoning with this particular mentee. So we wanted to spend some time talking about 3 concepts that are related to clinical reasoning. And those are critical thinking, reflective thinking, and problem solving. So getting into critical thinking, what is that? What is critical thinking? So it's where a person takes charge of their inherent thinking, and it can be seen through 3 perspectives: thinking ahead, thinking in action, and thinking back. So starting with thinking back, in mentorship, if you're having clinical reasoning discussions after the mentee has already seen the client, then you would be focusing more on thinking back. And that is about reflecting on the interaction. So asking questions like, why did you do things that way? Was there a rationale? Was it a good rationale? What worked and why or why not? What else could you have done? And what could you have done differently? So you'll see that a lot of the questions on this slide also relate to the clinical reasoning processes. So in terms of being flexible and considering options and patient context and information, these are all questions that relate to those processes as well. So moving on to thinking ahead. So in mentorship, you can use thinking ahead by asking a mentee to talk about what they will do next time they see a similar case, or preparing for an upcoming patient, or using a hypothetical situation. So thinking ahead is about being proactive, reviewing the patient information that you have before you see them, and considering other relevant information you may want to collect. You can ask questions like, how will you adapt your case history to best match the patient's context, their cultural perspective? How will you choose assessments relevant to the patient problem? And how will you ensure you have relevant equipment and materials? And then thinking in action. So in mentorship, you may see thinking in action when you're directly observing the mentee, or you could talk about this by simulating a patient situation. So thinking in action is thinking in the moment. So for example, the patient presents with a new issue not previously communicated or realized. So let's say the patient says, I've actually been having this problem for the last 4 weeks. So if they say that, how will you change directions? Will you change directions? Will you choose different interview questions? Will it change your assessment choices? Will it alter the management plan? So increasing strategies for reasoning in the moment.
Exactly.
Pass it over to you, Sarah, for reflective thinking.
Thanks, Samida. Yeah, so reflective thinking, I mean, you can see that it also links with critical thinking in terms of thinking back. But let's just, as we know, like much of the knowledge SLPs, audiologists acquire is based on our experience. So if I was to ask Samida why she performed a successful task a certain way, as an experienced clinician, she may answer, I don't know, that's just the way I've always done it. And a new clinician may respond, well, this is what I was taught to do. So, you know, we recognize sometimes we do things without really thinking about it anymore. It's such tacit knowledge that we almost lose that ability to put it into words. So this reflective thinking is a way to help uncover that tacit knowledge. We want to make it more explicit. How can you do that? You can practice by verbalizing inner dialogues and thought processes, thinking out loud. So again, this is where the clinical reasoning tool could come in really useful. The mentee could actually write their thoughts down. Sometimes by writing it down, it helps us think out loud. Write it down and then say it out loud between you, the mentee, and mentor. Other options could be using a self-reflection journal, thought maps. You really want to think about why you're doing what you're doing. So you want to encourage the mentee to ask themselves the following. And just as we said, this is very like thinking back in critical thinking. What did I learn from the therapeutic intervention? What went well and why? How could I have done things differently? What would improve the session? And I think any of us at any stage in our career, we're always doing this, asking ourselves our questions. Could I have considered other options? Could I have asked other questions? Could I have done other assessment? And then finally, problem solving. So looking at the problem solving as an active process. So first of all, you want to identify the problem. Obviously, today we're discussing insufficient clinical reasoning. You want to gather, analyze data. You're going to use the processes that you've identified between you and the discussion areas. It could be that intervention, it was the screening and assessment that was an issue, or it was the discharge and follow-up. You're going to look at generating alternative solutions and ideas using critical thinking, reflection, and problem solving. You're going to select and implement an action. So you are going to apply this to new patient interactions for the mentee during the mentorship and evaluating it. So that again is coming back to reflecting and learning from practice and using the clinical reasoning tool as a way, as a framework.
Great. Great. So let's listen to another audio clip. This is the same mentor and mentee having a conversation, and this time we're going to listen to the remediation. And as you listen to the clip, think about whether the mentee this time shows critical thinking, reflective thinking, and problem solving.
Thanks, Samida.
No problem.
Okay, I know you gave me some background, but it seems like you are going on memory. So let's look at the chart and you can tell me some more. Why was the patient referred to you for a hearing test?
Okay, let me have a look. Okay, looking at the chart, I can see now that the patient's hearing was symmetrical and stable before from past hearing tests. So he had a mild high-frequency hearing loss in both ears. But on this day, when I tested him, the results showed a moderate hearing loss in his left ear. And it looks like there's another test that was done by another audiologist on the team that showed an even more severe hearing loss in his left ear the week before. And I also see a note here that the ear, nose, and throat physician prescribed a steroid called prednisone to treat the hearing loss the week prior.
Okay, so let's take a step back for a moment because I'm interested in learning about your process around your assessment. So you've talked about the background information that you've collected. You have the hearing test report there. Can you think back and explain how you conducted your assessment? For example, did you choose certain tests and why not?
Right. Okay. Okay, I remember now. So in this case, I was assessing this patient to see if there had been any change in his hearing in the left ear since the treatment with prednisone.
Okay, so that's good. And how did you form your assessment process? Did you choose certain tests? Why or why not?
Well, what I did was I focused on the tests that needed to be done to see if there had been a change in his hearing for the left ear. So I always begin with otoscopy to see if there are any obstructions or abnormalities in the ear or ear canal. And I noted that his left ear was a bit red, but otherwise clear. And then I focused on the left ear since that was the affected ear. So I did air conduction and bone conduction testing and word recognition score. And when I compared the results that I got to the week before, I saw that there was about a 10 decibel improvement in his hearing in the left ear. So the treatment with prednisone had improved his hearing, but there was still a moderate sensorineural hearing loss on the left side. And his word recognition, I noted, also improved. So when I tested him, he got 60% of the words correct, whereas before the prednisone treatment, he wasn't able to decipher any words.
Okay, so your reasoning around the assessment is looking good. So why you focused on, sorry, you did explain why you focused on the left ear. So what was the step? Do you have any recommendations for the patient?
I remember I didn't have much time to explain the results because the patient immediately had an appointment with the ENT. So I did inform the patient quickly of the results. I noticed that I made a note to do an ABR possibly for the left ear, but I see now that the doctor had recommended an MRI. So looking back, I would have made different recommendations.
Okay, yeah, that's a good point. And it's always good to reflect and think about how you might have done things differently. So let's elaborate on that a bit. If you could go back knowing what you know now, how would you have done things differently?
Yes, I think I would have spent more time talking to the patient about the results and offering him options for support. Reflecting on everything now, I can see that the patient is going to be left with a significant hearing loss in the left ear, which is a big change in his hearing within a short period of time. So he's likely going to need some support with that. And if I could go back, I would have spent more time explaining to him what services are available. All right. Sarah, do I still have you with me?
I am still with you, Sumita, yes.
Okay, excellent. So moving on from that example, that was interesting to listen to. And so what did the mentor do differently this time and what did the mentee do differently? Well, definitely this time there was more prompting from the mentor. So there was much more encouragement from the mentor to think back, to do that reflective thinking that we talked about. And it was good in both examples actually to hear the mentor giving some positive feedback to the mentee. And I think that that really we saw a lot of development in what the mentee had to say as well. So an important thing this time was that the mentee was looking at the chart. So they were using that chart stimulated recall. They were thinking out loud. We could hear problem solving. So the mentee explained this time why they did the assessment the way that they did it. Why did they focus on the left ear, which tests they did. And they engaged in self-reflection. So when the mentor asked if you could go back, how would you do things differently? We heard the mentee elaborate on that. So from clinical reasoning processes, we saw application and linking of information. And I think we definitely heard a better rationale in that example. So we're going to end off here with talking about factors that may impact clinical reasoning. And we've listed 7. And in mentorship, what we've noticed is that the first 3 are often what we're talking to mentors and mentees about most often. So self-confidence, again, I mentioned at the beginning of the presentation that mentees are starting their professional practice, and often there's some confidence building that needs to happen at that stage. Having sufficient knowledge, and that's based on their experience level. So there is some time that may need to be spent on developing competence and developing skills, and that could impact clinical reasoning. But hopefully you would see that evolve over the 6-month mentorship. And then of course, personal factors and emotional state. So people have stress for lots of different reasons. They might be going through personal challenges and navigating lots of change. So it's important to keep that in mind as well, how those factors may impact clinical reasoning. Sarah, I'll turn it over to you.
Yeah, thanks, Samita. Yes, some other factors, maybe systemic factors. You know, sometimes there are admission discharge criteria in your practice, maybe age limits, maybe a cap on number of visits, so that can impact. Number 5 is therapeutic relationship boundaries, trust, and respect. And of course, it's important to establish and maintain professional boundaries and relationships. And we would suggest that you take a look at our guide and frequently ask questions on professional relationships and boundaries. Those are under resources on our website. And Samita, I think we'll be providing a few extra links to the clinical reasoning tool, and then some of these that we're mentioning as well. And then number 6 is personal perceptions, self-awareness and preference. So this is really the ability to self-reflect. Now, I'm assuming as students, a lot of work has been done on this. So as new graduates, hopefully your ability to do this is already very well honed. But of course, good insight is needed to be able to keep developing your clinical reasoning. And cultural awareness and responsiveness. So, you're always going to be aware to eliminate any barriers there may be, communication, hearing barriers, accommodating needs, being inclusive, providing fair, equitable action, just action in all professional situations. And it might be worth noting here, our new Code of Ethics, Principle 2A, talks about SLPs and audiologists shall not discriminate against anyone, and that includes patients, family, substitute decision makers, colleagues, or persons that you supervise based on any prohibited grounds listed in the Ontario Human Rights Code. And of course, these factors, it's not an exclusive list. There could be other factors. We just wanted to alert you to always keep in mind kind of a holistic picture of what you are dealing with during mentorship. Okay,
Definitely.
so I do believe this is our next time for questions. So we will
Yes.
be asking Jessica if you have a question that you'd like to pose from the audience.
And I know we're at, my clock says 12:59, so we've reached the end of the hour. For those of you who need to go, perfectly understandable. The recording and slides will be posted. We can stay, Sarah and I, for an extra few minutes to answer questions.
Yeah.
Wonderful. I do have a few questions. One is, if the mentor and the mentee has a disagreement in the rating, how can they go about working through that?
Yeah, I think that's a good question. Thanks. I think that's going to take some discussion for sure. So just letting each party, letting the mentee express why they disagree, and the mentor then explaining from their perspective why they feel more work might be needed. I think that openly discussing this is a really good approach. And
Yeah.
both parties reflecting maybe themselves, is there any maybe bias that they're bringing into it? Is there any preconceived idea that they're bringing into that discussion? In the first webinar, we talked about, as a mentor, when you're listening to the mentee's clinical reasoning, you're looking at the content of what they're saying, right? So you're not judging them on how eloquently they explain things or their choice of words to explain things. You're really looking at the content and is the rationale provided. But Sarah, do you have any more thoughts around that?
Yeah, I like what you're saying, Sumita. I mean, I think so much of it is related to obviously the mentee needs time to build up capacity to reason well, especially in complex situations, and build that confidence. So I think this is the whole idea. It needs to be an open discussion. If they can provide reasonable rationale, then that's what you're aiming to see. And sometimes we do have to agree to disagree. But and I think also to mention at any time, if there are really overriding concerns, that they should contact you, Sumita, as manager of mentorship as well, to discuss further.
And I just thought about, you can look at the practice standards together. You can look at professional, what does the profession generally, what is the consensus of the profession? You know, so if there's disagreement from one side, but there's evidence that there's consensus from the profession on maybe using a particular tool, using a particular assessment, then you can also turn to the standards and the consensus of the profession. But yes, you can contact me or Sarah, and if you'd like to discuss it further.
And then just because I'm mindful of time, I want to ask one more question that came in. It's more, so this person has said, I wonder if it would be helpful to teach these items at the beginning of working with the mentee, so that rather than correcting them after the fact, we provide something similar to errorless teaching like we would with a client. I realize this teaching is supposed to happen in grad school, but perhaps there should be something that we do so that we can let them know what our specific expectations are with our specific client population.
What are your thoughts around that, Sarah?
Yeah, I mean, I think we are saying that this tool is for you to use. I mean, we're requiring it at midterm and at the final report time, but absolutely, you're free to use it at any stage during the mentorship or otherwise. You know, you could use it for audits or yeah, it's open to be used as you find best. Yeah.
Yeah, we've heard of our colleagues using the tool for different purposes. And you know, you can, just as Sarah said, you can use it in mentorship, but you can use it, and introducing it at the beginning of mentorship is definitely something we encourage. We encouraged that a lot in the first webinar. You don't have to wait till midterm, although that's when it's required, but you could be doing this, you know, once a week. Pick a case, discuss it using the tool. And from what we heard from mentors when we surveyed them, both mentors and mentees find it very helpful.
Yeah.
So.
Yeah. Yeah. And it could be, you know, maybe they're really skilled in certain areas. They're great with language, great with articulation. But in the example we did today, actually influency was not a strong area. So maybe you use it in for a specific reason as well. That could play a part.
That's right. Any other questions, Jessica?
Not that pertain to this topic, but I did want to say that someone just said, thank you for making these audio examples far more true to real life conversations that we tend to have than we typically hear in presentations.
Good. Thank you. Yeah.
Thank you. So I will just take a moment. I don't know if the person who wanted to see where you find the tool is still online, but I'll share my screen for a moment. You should see the CastlePo website.
At
Sarah,
the
is
moment,
that what
we
you
see,
see?
yes, fantastic.
Okay. So if
I
you're
live
listening,
further away, it's always a bit delayed. Go ahead, Samita.
so just to show you where you find the clinical reasoning tool. So if you're on the web page, you would go to applicants. Then in the left-hand bar menu, you'll find mentorship. You click on it. And that takes you to the mentorship overview page. And if you continue to scroll down on this page, you'll find lots of information. So you'll find the past training modules. And then you'll come to a chart that has the guidelines, the contract, and then there is the clinical reasoning tool for mentorship. So that's where you find the tool. And I hope that's helpful. It'll be in the recording of the webinar in case the person who asked that had to log off.
One thing I would love to say again, if we didn't respond to your question, someone will email you with a response as soon as
Yes.
possible.
Yes.
Thank you.
Okay, so with that, if there are no more questions, just want to thank everyone for joining us. Thank you very much for taking the time to listen to this presentation. We hope you'll find it very helpful in mentorship, outside of mentorship, and we wish you a nice afternoon and a nice weekend coming up. Take care.
Thank you. Bye-bye.